Hello to everyone, dear colleagues, dear friends of endovascular interventions. Today it's my great pleasure and honor to announce a new webinar as a part of our D2D educational platform. As you know, the webinar will be held in the English because we have very important international physicians and we have a very important lecturer. The topic of our webinar is how to solving the problem of AAA hostile neck as a part of the endovascular aortic therapy. In addition, it is my great pleasure to present our distinguished lecturers today. First, I'm very happy to introduce Professor of Vascular Surgery from Frankfurt, Germany, our friend Konstantinos Donas, a great expert in the endovascular treatment of AAA using the technique of parallel stent graft, so-called chimney or ChEVAR. And second, our friend, member of HEVI and assistant professor Vjekoslav Tomulić, a physician with significant experience in using EndoAnchor in solving the problem of the hostile neck. I hereby encourage all of you to ask questions in the section Q&A at the bottom of this page during the webinar, which the lecturer will answer at the end of his presentation or at the end of this event, especially after who want to ask something for Professor Donas. Please give a question early in this first half of presentation. I also want to emphasize that all our webinars and hands-on will be recorded and will be available on the HEVI YouTube channel. Now we can kick off with this webinar, and I would like to invite my friend, colleague, and Vice President of HEVI Initiative, Dr. Tomislav Krčmar, and to give us a short introductory lecture and to introduce us to the problem of the hostile neck. Hello, Tomislav. Hello.
Hello.
Floor is yours. Hello.
Thank you, Dražen. Thank you for a kind introduction. Let me say thank you for Professor Donas to accept the invitation to be with us in the afternoon and speak about one very interesting and important topic. Thank you, Assistant Professor Tomulić, also to be with us. Me and Dražen, as Dražen also said, we will do a little bit of moderating this event. In the beginning, I will address the problem in just 5 slides. I will be short and I will just now share with you my presentation. 1 second. Here we are. I will just say a few sentences about limitation of standard EVAR and hostile neck anatomy. Of course, the limitation of standard procedure EVAR is mostly anatomy. If we are speaking about anatomy, that is that the neck, the diameter of neck should be at least 28 millimeters or less, or the length of the neck should be 15 millimeters or longer. But and the angulation of the suprarenal aorta according to the axis of the abdominal aneurysmic sac should not be more than 60 degrees. And we are very happy when we have such kind of an anatomy, and this should perform well. But in the real life, 20 to 20% of all cases referred to us are not so simple. They are more anatomically demanding. And why is that? Because sometimes the neck is not so long enough, then we have a short neck, then we have angulation of the suprarenal aorta, which is more than 60%. The actual neck could be tapered, could be conical, and then the neck has calcification if it has thrombus or calcification more than 5% in the diameter, then should also be referred like it could be some sort of hostile neck. And then, of course, there's sometimes we do even if diameter of the neck is more than 28 millimeters. So if we just see another schema, then we can say that the hostile neck anatomy is because we have short neck, conical neck, angulated neck, reverse conical neck, barrel neck, or double barrel neck. Why is that? And then we can memorize this with SWOG acronym: S for short, V, W for wide, A for angulated, and C for conical. This doesn't describe all the main features of the hostile neck because of thrombi and calcified neck is not here, but maybe I think it's good acronym to remember it. And why is that important? Because of type 1A endoleak is associated more with hostile neck anatomies, and we have type A endoleak, then SEC may growth, and then sometimes we could have migration of prosthesis. That's all for me. I think I addressed the topic and the problems, and Dražen, can we continue?
Thank you, Tomislav, for your short but very precise presentation. And now I would give the floor of our distinguished lecturer, Professor Konstantinos Donas from Frankfurt. Hello, Konstantinos. Please, you can start with your presentation.
Yes, thank you very much, dear Dražen, dear colleagues. It is a great honor and opportunity from my side to give you some insights about this very interesting topic. I am more than glad to have the opportunity to be in contact with our friends and colleagues in Croatia. You know that I'm coming from a little bit south from Greece, and I'm very happy to have this contact with you. So let me speak about an interesting topic, the treatment of hostile necks based on the chimney endovascular technique. Let me share the screen in order to have the opportunity to present you this topic, and please feel free to ask me to present your questions. There is no doubt that the treatment in general is not standardized. I think we have many options, and the main problem is that we don't have a clear algorithm. So let me give you some insights about the chimney or snorkel endovascular technique. How can we treat the patient? When should we treat the patient by this approach? And where are also the limitations? When should we avoid it? Because we will have suboptimal outcomes. What is exactly the chimney or snorkel endovascular technique? So if you see this kind of aneurysm, so you see, as we saw in the very nice presentation from Dr. Krčmar, we have a very short and angulated neck. So we have at least, let's say, 6-5 millimeter infrarenal neck in an angulation like this. If we try to treat this patient by standard EVAR, we're gonna lose probably 2 or 3 millimeters per se, and we will have the high risk of type 1A endoleak. So there is a need to create a new seal zone, a more sufficient zone. And in this context, this was the reason why we adopted the chimney technique by placement of covered stent, in this case in the left renal artery, in order to deploy your device at the orifice, as we see here, of the right upper right linear artery. And you see by this, you are creating a new seal zone of 20 millimeters. And due to the fact that we want to have a patent left renal artery, we are deploying the covered stent, the chimney graft, in a parallel configuration outside of the main abdominal device, as you can see here, outside of the device, leading to perfusion, maintaining the perfusion of the left renal artery. So by this, you see that we are deploying the endurance device higher, and by this, we are creating a new seal zone leading to exclusion of these aneurysms, as we see here. As you probably know, there is a well acceptance of these techniques based on the European Society for Vascular Surgery guidelines. We worked on this, and with the support also from colleagues from this area, also from Dr. Krčmar, we create these guidelines, recommendations, and up to now, ChEVAR is recommended to be used as an alternative to fenestrated endografting when fenestrated endografting is not available. And unfortunately, there are many countries in the world in which fenestrated endografting is not available due to the cost, due to the sophisticated sizing and planning and deploying, but also due to the fact that very often we have hostile anatomies. And you know that for fenestrated endografting, you have to have a straight neck, you have to have friendly access, but very often the reality is completely different. So we have very often hostile necks and hostile iliac access. Let me show you a few examples. So you see these anatomies, which are anatomies which we have very often in our clinical practice. So you see the severe angulation of the neck, you see the severe calcification of the iliac arteries. And based on this, we need a device which is flexible to overcome the anatomical obstacles as we see here in the access, also a device which is flexible to accommodate these severe angulations. And this was the reason why we adopted the chimney technique as an alternative to the other endovascular options. It is very important, and this is also very important because you know how often we have at meetings these controversies and let's say debates between FEVAR, ChEVAR, but you have to realize when we are treating patients with ChEVAR, there are in 70% outside of the IVU for FEVAR due to the hostile aortic neck. And if we include the severe calcification, elongation of the axis, there are almost 90% outside of the IVU for FEVAR. So this shows that there is no need for comparison and the techniques are complementary. In the literature, we have a controversy. We have centers which have suboptimal outcomes and other centers which have very good outcomes. And let me give you a few insights, which is the reason for this divergent experience. So recently we read in the European Journal an experience from the French Society, which included many centers and treated patients with ChEVAR, and they highlighted that the results are very concerning and that we need more, let's say, sophisticated planning and sizing. And if you see here, the implanted stent grafts, you see a heterogeneity. You see the Zenith device, the Endura device, the Gore device, the Endologic device. You see also different chimney stents, bare metal stents, covered stents. So it is, sorry for saying this, like a Greek salad. And this is exactly the reason why we tried from the beginning to distinguish that chimney, it doesn't mean you can combine everything with everything because you have in your stock different abdominal devices, but you have to learn which combination performs well and which combination performs not well in order to avoid it. With other words, if you have in your center experience with a Cook device or experience with a Gore device, it doesn't mean that you have to start to perform chimney with these devices, combine everything with everything, and expecting that you're going to have good results. And let me show you why. The colleagues from this French experience highlighted that there is a lack of standardization of the technique, and this is very important in order to have good outcomes. This was the reason why in Münster in Germany, in my previous hospital, we tried to standardize and evaluating only one combination. So we evaluated the combination of the Endura device as a flexible device, low profile device, a device which is very good in angulated and complex hostile necks, in combination with a balloon expandable covered stent like the Advanta, which has a high radial force, and you have less risk of compression in case of placing these outside of the Duran device as a chimney graft. And indeed, our 10-year experience showed very good outcomes for this specific combination. So we have a clear protocol, and we had a very good midterm outcome regarding the freedom from chimney graft occlusion, the decreasing or stabling of the aneurysm sac, and the freedom from late type 1A endoleaks. And I think this is very important, and I would like to give you an insight why this combination performs so well. So first of all, you can realize by these images how complicated anatomies were treated by ChEVAR. And I think this is very important. So you see that in 31% of the treated cases, you had an angulation of more than 60 degrees, which is a completely anatomical condition outside of IVU for fenestrated endografting. So you can treat these anatomies with fenestrated endografts because they are so severe angulated. And if you put a fenestrated device, you're gonna lose the fenestration from the orifice of the renal artery, with a consequence that you're gonna lose the perfusion of the renal artery. And this was the reason why we adopted the chimney technique and we started evaluating. Well, you see also on the right side how angulated is also the anatomy in 23% of the cases. So you see that we treated very complex hostile necks, very short necks or no necks, as you see here in the juxtarenal or pararenal pathology, and in 24% were outside of the IVU for juxtarenal or pararenal arteries. It was a suprarenal aneurysm. And the big issue for the chimney endovascular technique is to have a balance between the risk of type 1A endoleak. So you don't want to have gutters which persist. And as you can see on the left side, the gutters are the channels between the covered stents and the abdominal device, but you don't want to have an excessive oversizing to compress your chimney graft. So this was the main, let's say, work of us, of our group, to identify the ideally oversizing of the aortic stent graft, having on the one side enough material to wrap up the chimney graft and not having a persistent gutters, and on the other side to have enough material but not compress the chimney graft, because you know that you are putting a radial force in the chimney graft and you need a balloon expandable cover stent which has also radial force to avoid the compression. And therefore, due to the fact that we have different materials, we worked for many years in vitro and in vivo in order to identify this ideally oversizing. First of all, which is also very important, is to know where should you measure the diameter in order to decide the oversizing. So keep in your mind that you have, in many cases, a short but present infrarenal neck. And in this nice drawing, if you put double chimneys for the right and left renal artery, you're gonna have a new neck till the orifice of the SMA. So the entire neck would be the sum of the infrarenal and new neck. And this is the entire seal zone. So based on this, you're evaluating the diameter in the proximal, in the middle, and in the third last segment. And you have to have the mean of these three measures in order to identify the degree of oversizing. So let me give you an example. If you see in the proximal, you have a 22 millimeter, then you have 25 in the middle, and then you have a 27. So the mean of 22, 25, 27, focusing mainly on the distal part, will give you the diameter of the seal zone in order to decide 30% of this as aortic oversizing. So this is very important. And here you see again what I defined as seal zone. So the sum of the infrarenal and new neck. This is very important when you decide to perform ChEVAR. And based on our work, we identified, having in mind that you are losing always 3 millimeters when you are deploying the device, that you have to have an oversizing between 30 and 40%, and a new seal zone between 20 and 25 millimeters. So this is very important if you want to have durable outcomes with ChEVAR. So don't be afraid to oversize your aortic stent graft. Please oversize not less than 30% and create a new seal zone of 20-25 millimeters. And this is very important because if you have, for example, a diameter of 30 or 31, 32 millimeter, don't perform chimney because you're going to have an oversizing of less than 30% with a 36 millimeter device, which is the maximum diameter. So this is also important to know the limitations of the technique in order to decide which kind of device you're going to use. The reason why I highlighted the use of the Endurant device, because we started many years before Medtronic came to the game, we see these very nice examples of the CT scan reconstructions, and you see the ability of the Endurant device to expand between the two stents. You see the short M-shaped stents, so you have the possibility to expand 12 millimeters between the two stents, as you see here, and this leads to gutter thrombosis, because by this expansion, due to these very short M-shaped stents, you are filling the gap of the aneurysm sac, and this is the reason why we don't care so much about the gutters, and we have the experience that in the first in-hospital CT scan, the gutters, which are probably normal to see at the completion angiography, will disappear. So this is something which is only possible to see with the Endurant device, this expansion, as we see here, in a very short segment. And this is the reason why the gutters will be thrombosed over time, and it will be no issue leading to sufficient aneurysm exclusion. Regarding the iliac access, I highlighted how complex were the cases regarding the access. You see that we had a bilateral hostile access of 44% almost, very, very demanding access. And this is one of the main reasons why we perform the chimney technique. So if you're gonna have a CT scan and you will consider which kind of technique I'm gonna use, check please the access, because treatment of hostile necks starts from the access. And if you have a hostile neck, but also hostile iliac arteries with severe calcification, elongation, then there is no place for devices like fenestrated endografts. So you need something with a low profile, something flexible, and this is why we adopted the chimney technique at the beginning. Here you can see the recommendations from Medtronic regarding the chimney endovascular technique. You see here on the left column the diameters of the neck for standard EVAR. You see on the right side for ChEVAR, and you see that for ChEVAR, we have a limitation regarding the diameter, so not more than 30 millimeters, because if you have more than 30, I would say 29, then you will have an oversizing of less than 30% if you take the 36, and if you perform ChEVAR, you have a high risk of having persistent gutters and endoleaks. This is what we learned. This is what we published recently in the European journal, the Protagoras 2.0 studies, that regarding the recommendations, be aggressive with ChEVAR, at least 30% for short juxtarenal, but one chimney graft, and 35% if you have two chimney grafts. So you need more material, and don't forget the sufficient seal zone of 20-25 millimeters. Let me show you now some logistics, which are also very important. So of course you can perform ChEVAR by C-arm. We have a modern C-arm, but if you have the opportunity to have a hybrid room, of course you have a big benefit regarding the imaging, regarding the fluoroscopy time, the radiation exposure, and of course there is no doubt that complex EVAR is better to be performed in hybrid OR rooms. Very important for the chimney technique is you have to have good, let's say, orientation of your wires, of your sheaths. So you need long tables it is very important the setup in order to have an overview for your catheters, as you see here. Here is the position of the patient. So you see that we need access to the groin and to the left upper extremity. We would like to perform ChEVAR by cutting here the axillary artery, so you are closer to the descending aorta, avoiding, 15 almost centimeter if you puncture the cubital artery. So probably it is better to start with the axillary artery. Here you can see a very nice intraoperative image. This is the position of the operator. So we would like to exposure the axillary artery, and the benefit is that foam caliber is better than the axillary artery, compared to the brachial artery. And of course, if you perform double chimney, you have the possibility with a distance of 1 centimeter to puncture the axillary artery to bring your first 5 sheaths and later the 7 French sheaths. For me, this is the ideal anatomy to start performing ChEVAR when you have a left, let's say the lower renal artery has a distance from the upper renal artery, so you can perform single chimney because you're going to create a new seal zone of 20-25 millimeters as we recommended. Very nice is the fact that you don't have a severe calcification of the orifice of the renal. We know the more calcification, the complex is the advance of sheath from the upper extremity. And this, of course, increase the operation time, increase the fluoroscopy time, increase the contrast medium agent dose, etc., etc. So this is a very nice anatomy to start performing ChEVAR, but keep in your mind one important point is the angulation of the left renal artery. And I'm going to highlight this also at the end of my talk. We learned that the more angulation, the higher is the risk. If you put a rigid Advanta stent, you can have a knick stenosis. So it's better to avoid, so to put a short chimney graft, avoiding the involvement of this angulated segment. At this case, it was one of our first cases. You see that we line it with a bare metal stent in order to improve the transition in this angulation, but it is recommended to put a shorter chimney graft, avoiding the angulated segment of the renal artery. Here is a challenging case of a type 1A endoleak. You see an old talent endograft, and you see the huge type 1A endoleak. The patient was symptomatic. The other problem is you see the severe stenosis and calcification. So we have to overcome it, and we put a tube. You see here in a chimney configuration, how is the sizing and planning. So we created with a double chimney for the left renal artery, a new seal zone of 22 millimeters. And we had an oversizing of 30% with a 36 device. Here is the result. With a double chimney, we excluded in the same evening the symptomatic type 1A endoleak. The pre and post-operative CTA. And at the end, I would like to highlight 2 critical periprocedural issues. The angulation is very important. If it's possible, put a short chimney graft, avoiding the angulated segment. This is what we learned and published last year. And also important is don't put your chimney graft very high, because you can have a problem with the pins of the suprarenal stent. Perform the proximal part of the chimney graft should be in the middle of the suprarenal stent in order to have enough distance from the suprarenal stent and avoid an interaction of the pins with the balloons of the chimney graft. Thank you very much.
Thank you, Konstantinos, on your very comprehensive and excellent presentation and lecture, in which you pointed out very important parts of this procedure, especially for our less experienced the physician in auditorium. And now we can start with questions for you from Q and answer section. We have three questions. First question is when to opt for fenestrated and when for ChEVAR as a method of the treatment.
Well, it is a good question. First of all, you have to see the morphological anatomy. So if you have a, let's say, a straight neck, short but straight, and good access without severe stenosis or calcification, you have a very good anatomy for FEVAR. There is no point on this. What I'm thinking all the time when I speak about FEVAR is you are involving per se the superior mesenteric artery either as scallop or as fenestration. And we don't have, Dražen, up to now a dedicated, approved bridging device. So now the Bentley group started a prospective study. But what I'm thinking is, if I don't have for this indication a covered stent from each company, how can I put this in the superior mesenteric artery? Because you know very well, if you have a stenosis, if you have an occlusion, you're gonna have acute abdomen and probably the patient will die. And we don't have autopsies for each cases in order to see the real incidence. We are publishing this, we have done a nice systematic review, and in the literature, you don't have this data, and nobody can say to me that you can perform duplex and you can see indeed in an obese patient how is the SMA and how is the patency of the device. So this is for me something which I don't like, but there is no doubt a short and good access from below neck is a good indication for FEVAR. Of course, the other question has to do about the costs. For example, I remember from the first 100 chimney cases, 45% were octogenarians. So you have octogenarians who are relative well, and you can say the gods should decide if the animal will rupture, and therefore we perform ChEVAR. So there is less expensive, we learned this. If you have performed single chimney, if you have any issues, you have issues with one renal artery, but you don't have issues with the SMA and with the other with the other renal artery. So probably for octogenarians, for older patients, for patients with good anatomical conditions, as I showed, with involvement of only one renal artery, is ChEVAR beneficial and should be the first choice.
Thank you, Konstantinos. We have now questions from Assistant Professor Končar. Igor Končar is in auditorium.
Yeah.
Yes. Hi, Igor. How do you check patency of the chimney in the early post-operative time, and what if thrombosis occurs?
This is a very good question, Igor. So the answer is very easy. If the patient has no symptoms, then the chimney is open. because
everything is good.
Yeah, because in my experience, in any occlusion of a chimney graft, the patient came with flank pain suddenly, and we learned this, it happening in the first 3 months. So the patency is a very nice, let's say, evaluation by these symptoms. But we have to say, of course, I would do a CT scan evaluation in the hospital to have the first imaging and the first impression. And very important are the first 3-4 months. So what we learned is this is the time of symptoms of occlusion, because it seems if you have an occlusion of the chimney graft, you have probably a suboptimal expansion of the chimney graft during the periprocedural issues, and the patient will come very shortly. So you can't do anything more than give him dual antiplatelet therapy. If the first CT scan is okay, I would do the next in 6 months, and then to decide based on the symptoms. So you ask me if you're gonna come with chimney occlusion. This is a very good question, and I wanted to have a technical note. How can we treat it? First of all, it's very difficult a chimney graft occlusion to be reopened. Why? Because you have the suprarenal stents of the EndoAnchor device, and it's very difficult, Dražen, to overcome, not with a wire, but with a catheter and with a sheath, and to have a stable position to recanalize the occlusion. We used in the past aspiration systems like the Penumbra, and in the majority of the cases, therefore I highlighted avoid to line it, was a lined chimney graft, which means a chimney graft, and was additional placed a bare metal stent to have a better conformability. And this means that you have in 6 millimeter 2 devices, which seems to be not good for the patency. Therefore, we learned this, and we recommend now either to use short stents in order to avoid the angulated segment, or to use, for example, from the Bentley, the big graft, which is very flexible, and you don't have to put additional another stent to improve the transition. So with other words, the recanalization of occluded chimneys is demanding, and it's difficult, but we have, therefore it's good to have an aspiration system like Penumbra or Jedi in your stock.
Okay, and last question, because we know that you are on time in 5:30 with other obligations. What is the recommendation for the post-operative medication? Double antiplatelet, triple antiplatelet, you know?
I would say that double antiplatelet therapy, aspirin, clopidogrel for at least 2-3 months, and then monotherapy with aspirin. I don't know if we can. I had one case, the patient stopped clopidogrel and came with stenosis and symptoms. I think at least 3 months is necessary to have the dual antiplatelet therapy for this critical period after the technique. We can answer also another question if you have. We have also 5 minutes.
Okay, we have one basic technique, question. When during the procedure you implant stent in the renal arteries, stent graft in the renal arteries?
Yeah, you mean from the technical point of view?
Technical point, minus step.
Yeah. After the deployment of the chimney, of the abdominal device, you have a clear impression where is your covered, where is the fabric, and where are the suprarenal stents and the pins. And as I showed, you have to be in the middle of the suprarenal stent. So you have to remove the sheath at the orifice of the suprarenal stent pins, and then deploy the device. So at the end, I would deploy the stent. After deployment of the abdominal device, you have the sheaths in the renal artery, so you are removing back the sheaths, and then you're deploying the chimney grafts.
Konstantinos, thank you again. Thank you again for your participation and for giving us very important information about parallel stent grafting ChEVAR, and I hope so that in near future we will cooperate again.
Yeah.
And it is my honor to be guest today for us. And
no, thank you. Thank you, dear Dražen. I'm very pleased that I was part of this very successful idea and project which you had in your mind. I'm very happy. You know that I'm living in Germany, but I'm feeling very close to you, Igor, and all the friends from the area. And I'm very happy if I can participate and give you, my experience, whatever I can, in order to help my good friends and colleagues and physicians in Croatia. I wish you all the best, and I'm very happy to see you again in different topics. I'm very pleased to be back in the future. Thank you very much.
Thank you, Konstantinos, and everything best.
Bye-bye. Thank you very much.
Bye. We now going further. Tomislav, you can take a floor.
Thank you, Dražen. Thank you, Professor Donas, for very interesting and very important topic, and all the tips and tricks and advices. It was, I think, it was very interesting. And now I will announce my dear colleague, my dear friend, Assistant Professor Tomulić is chief of the cath lab, one of the cath lab in which I perform and I spend every week. And I'm very pleased to announce him to give us the lecture on EndoAnchor Heli-FX endograft fixation of EVAR from indication to implantation. Please continue, Vjeko.
Thank you for your kind introduction. Okay, So I'm going to tell you something about another technique, how to fix some issues with the hostile neck. And actually, it's not an option that's in against ChEVAR. Actually, it's something that is complementary, and you have to have a thorough consideration before implantation of the stent graft to choose either this suture-based technology or ChEVAR if you want to deal with the hostile neck. So as you already said, hostile infrarenal neck is something that's less than 50 millimeters in length, that's over 28 millimeters in diameter, or it's severely angulated. And as you can see, almost these are some of the EVAR devices. There is some IFU consideration that you have to take in mind when you're dealing with it. And actually, almost all of them have this 10 millimeters neck length as a contraindication for usage. Also, we have severely angulated infrarenal neck as a contraindication or precaution when we deal with these devices, and you can only use Endurant according to the CE mark, not according to the FDA, if you want to treat some severely angulated aneurysm. So when you talk about that, you see that late failure is still an issue in our after our interventions, and we have these reinterventions, we have our sac expansion, and that leads to, of course, bad results, and even to the death of the patient because of the rupture. So that's still an issue with these the devices that we use today. And if we treat, and we tend to treat more complex cases, then we have more issue with this and more endoleaks type 1. So if we go to the meta-analysis of 7 major studies in EVAR, and which compared outcome in hostile versus friendly neck anatomies, that was done by Antononiu, and you see that its major findings was that secondary procedures are, of course, more frequent in the hostile proximal necks interventions. And of course, if we have endoleaks type 1A, almost 5 times more likely at 1 year after endograft is implanted in hostile neck. That leads to almost 9 times greater hostile neck aneurysm-related mortality. So the ChEVAR is, as Professor Donas already said, is a new sealing zone. You are creating a new sealing zone for the device and to deal with the aneurysm. With the endosuture technology, you are fixating the graft on the place where it was intended to be implanted, meaning infrarenally. The concept was to bring some surgical methods to the endovascular medicine. And if you're watching these commercials that were running before our this webinar, almost all it was said there. So I just I'm gonna repeat everything that's already said or shown in the videos. So the idea was to expand the indications for EVAR with this endosuture repair technology. It was to reduce the need for follow-up, to prevent and to treat endoleaks type 1, and of course to replicate surgical results. The first results, the first experience with this device was published from 2012 onwards, and these are some of the first studies that were published for this endo-anchoring devices. And you see that it was done in a primary EVAR, meaning like a prevention of endoleaks, then for EVAR revision for migrating of the grafts and type 1A already endoleak already developed. then some TEVAR experience, and some experience in replicating surgical anastomosis and arresting neck dilatation, which is also very important in these patients. And then this is the post-marketing study, that the anchor study that's everybody is referring to in this when you talk about endo-anchoring. And there is a short neck cohort comprising of 70 patients of that was and this cohort was published. They were dealing with almost 17% of symptomatic cases and 3% ruptured cases. So almost all, more than 2/3 of them were male. And you see the anatomical characteristics and aneurysm measurements, meaning that the neck length was a little bit less than 7 millimeters, and there was some thrombus and calcium in the neck, 1.3 millimeters average neck calcium and 0.85 millimeters thrombus. The angulation of these aneurysms wasn't so severe, so meaning 20 degrees, that's not bad. And this is an interesting slide because you see that there are two cohorts in this study altogether, in anchor study, and this there's a primary implantation of the anchors and the revised cohort, meaning when you have to have a secondary intervention in the endo-anchors on the already migrated or endoleak from a previously implanted endograft. And for this short neck cohort, only 20% of the patients were dealt secondary. So 80% of all the patients was because of the concern for late failure of endoleak or prevention of neck dilatation, meaning the implanters, operators successfully recognized the risk of all these things and implanted endo-anchor placement, endo-anchors in these patients. So these are the results, and as you can see, it can be done very easily and very fast, meaning 70 minutes for the endo-anchor implantations, not increasing much the fluoro time. And the number of endo-anchors which were implanted was in average 5.5. And these are the results at 1 year, meaning that it successfully, in a large number of patients, large proportion of patients, stopped the neck dilatation, and there was only 1.9% of the type 1 endoleak, and no conversion to open surgery, and no rupture in these patients. So based on that anchor and registry, and also all the other studies that were published before it, these are the recommendations for the patients, so we can see which patients can benefit from this technology. Meaning we can do it in prophylaxis for the hostile anatomy or the normal anatomy even, or for the treatment of already migrated stents, late term endoleaks, and to augment stability, meaning stabilize the neck of the aneurysm. So if of course hostile anatomy is self-explanatory, but even if we tend to treat younger patients, or if we are worried that there will be no option for another safe reintervention in these patients because of the severe comorbidities, maybe that's also the patients that have benefit from implanting these endo-anchors in the primary intervention. So what is it? What's this technology? It's an on-label, meaning it's already approved from the regulatory agencies, and it's off-the-shelf technology, which allows us to fixate the stent graft to the aortic wall in the challenging or hostile infradiagonal neck. It does not inhibit future interventions because its design was that there is this sharp suture-like edge that's going into the aortic wall through up to the adventitia, and there is this crossbar part that's stopping in the endograft, and that allows us to pass with another devices or even to have another intervention if needed. We put it in through the 16 French deflectable sheet for the EVAR and 18 French deflectable sheet for the TVAR, and you have this battery-powered applier and one cassette with 10 EndoAnchors. Usually, that's enough for the patient. These are some sizes and other technical specifications for this, meaning that for the EndoAnchor system for the EVAR, you have two options, 22 and 28 millimeters, depending on the aortic neck or the implanted endograft. And for the thoracic, these are the options. You have three options, 22, 32, and 42 millimeters, and these are the recommended aortic necks in this case. This system is indicated for use, and it was tried either in vivo or in vitro with all these grafts. And as you can see, these are the most used grafts, I think, in Europe. Of course, the Cook, the Gore, and the Medtronic, and even the German-based Biotech, all these grafts were tested with Heli-FX, and there are no tear in the endograft fabric when you use these endografts. You have to be cautious with the endologics, especially the Pauling graft. It's contraindicated to use it with it, but also with all these cuff sealing technologies that endologics has for the other grafts. Fortunately, in Europe, they are not so frequent, and you don't have to worry, I think, about that in at least in our region. Of course, there are some other allergies and bleeding diathesis for the implant that you have to be worried about, and don't use then this device. And actually, it's made from this nickel, chromium, molybdenum, cobalt alloy. There are some precautions when using it, meaning that all the studies were done with these anchors delivered in the grafts in the necks that were more than 4 millimeters long. So these are the precautions, and you have to use it in the neck from 4 to 10 millimeters in length. And there is also, of course, the maximum infrarenal neck diameter of 32 millimeters, the neck angulation that's maximally treatable, again, 60 degrees. And this is very important. You don't, if you have calcium or thrombus or plaque that's comprising more than 50% of the circumference, or it's more than 2 millimeters in thickness, then probably this technology won't work. You have to choose another means of fixating and preventing endoleak or migration of the stent. So one case for to show you only the implantation of the device. So this was one of our patients. So it's a 70 years old male which has some comorbidities, and he had asymptomatic 6.3 abdominal aortic aneurysm. We did it as we usually do with percutaneous approach, cath lab and the local anesthesia and conscious sedation. And you can see that if you remember the slides from Dr. Krčmar, that it's a severely angulated neck with 22 millimeters on one side, and on the left 7 millimeters long neck, and the neck was 30 millimeters in diameter. And we choose to primarily implant endoanchors after the stent graft implantation to prevent endoleak, acute endoleak, or even a stent migration or neck dilatation. So this was the result after EndoRun 2. We chose, of course, this 36 diameter for this procedure. And as you can see, even here, the result was, I think, very, very good. But then we proceed with EndoAnchor application. So this is when we put the sheet in, and this is the applier that's coming to the end of the sheet, and then with the simple rotating the knob on the sheet, you flex it and you position it to the wall of the stent graft. You have to put it, you have to apply it and to suture the first or the second graft, covered graft on the endograft. No, so this is the device preparation. When you get it from the box, you just push the back button. It's not very complex, and usually after 1 or 2 implantations, you are very confident in using them. Then you put the plier in the cassette and the anchor loads, and then you put it the applier into the sheet, and that's practically it. When you, as I showed you before, when you have the smaller grafts up to 28 in diameter, then you can put only 4 anchors, and if you have larger grafts, then you have to put at least 6. That's the recommendation from the Medtronic when using this technology. So actually, if you do it for the 4 grafts, then you have to put to be in the 2 positions to be perpendicular one to the other, and to have four sutures that are evenly distributed over the circumference of the graft. And if you have 6, then you choose 60 LIO AP and 60 LIO, and then deliver the sutures. And to successfully deliver the sutures and to be sure that it's through the endograft and into the aortic wall, you have to pass some criteria, and actually that's the acronym for it, the PASS. So you have to get good position, a position, and then you have to deploy it in 2 stages. First, the position, it's very important to have in mind that there are 2 markers on the end of the sheet, and it has to be straight, and then you know that you are in the lateral position, and then you can have good position on the C-arm and on the wall of the aorta. Then the apposition, meaning that you push on the applier and the sheet has to go back, meaning that you have the good apposition on the aortic wall, and then you press the button forward 1 time. It deploys the first half of the anchor, and if you're satisfied with the result, you push it again, and it deploys the second part of the anchor, and you are practically done with the positioning and deploying. This is how it looks real time. So on the left, you see that we pushed, we get a good apposition, the first and then the second stage with the good deployment of the EndoAnchor. And this is the result after, I think there are 1, 2, 3, 4 at the time implanted in this patient. At the end, we implanted a total of 7 EndoAnchors in this patient, and this was the final result after the implantation. And on the 1-year follow-up, it looks something like this if you've done it right. So total exclusion of our aneurysmic sac. You see here on the right picture the dots of EndoAnchors, and this is how on the left you see how it looks like on another projection. So to conclude, the Heli-FX EndoAnchors are easy to use. It's an off-the-shelf solution. You don't have to have many sizes, only the 2 different sheets. There is no need for renal artery catheterization or axillary approach, and it's very, very procedurally efficient and fast. Thank you for your time.
Thank you, Vjeko, for a very nice presentation and demonstration of the technique. We have some questions. What was the shortest neck which you fixed with EndoAnchor?
5 millimeters. That was the shortest. The recommendation is up to 4.
Up to 4.
Yeah, the 4 is the minimum, and if you have 4 or less than 4, actually, because then you have to, I think, choose another option, EVAR or ChEVAR, because you cannot be then sure where to stop with the graft, and where you have to be sure then to put it in the first or the upper part of the first covered stent, and that's very, very hard to do.
I have another question related to this question. How do you size the graft when you have conical shape and you are attempting to treat it with endoanchors? Do you size it on 3 or 4 levels and then calculate?
Yeah. Actually, like Professor Donas said, I measure it above the renals, in the renal region, and just below it. And then you have a mean value, and then you choose the graft and you size it aggressively. You size it you oversize it aggressively, no? So you have to be at least 25 to 40% in oversizing when doing it.
Another question, can you tell us what are the potential advantages of EndoAnchor technique over the ChEVAR method?
These are complementary, actually, methods. And for some patients, you have to choose ChEVAR because even this technique is not adequate. Meaning, if you have some concern that if you have some thrombus or calcium that's more than 2 millimeters in diameter, and then you won't be able to fixate the endograft to the aortic wall. And that means that you have to have a new sealing zone, meaning you have to do ChEVAR to be sure that it works. Calcifications in the neck are actually not very friendly for this technology, and you have to choose the patients accordingly. No? So it depends on the patient. You have to analyze the CT and then decide what to do. No?
I think it looks to me like if you have combination of the severe angulation and the short neck, that I think it's tricky. But you saw, but you actually that was
60.
First,
yeah, I think our patient had more than 60 degrees angulation.
Right. Yeah.
Yeah, so this patient had more than 60 degrees angulation, and I think it can be done, but actually he had no thrombus, no calcification in the neck. So it could be done, and as you saw, and it's very, very often. So if you have angulated necks, you have one side that's 15, 20, 25 even millimeters, and the other side is 6, 7, 8 until in length, no, and these patients can be successfully treated with endoanchors.
I think this case which you showed.
But that was, I think, the first one. Yeah,
it was the first case, but also I think it could be done with ChEVAR with one stent graft to one renal. Actually, it's more or less.
Actually, this patient is it's a ChEVAR candidate or ESAR candidate. It's not a FEVAR candidate because you have a very angulated neck, and the opening of the FEVAR won't work in this case. Because you
I have only one comment. In ESAR technique, we avoid the cannulation of the renal arteries, and we can avoid the complications related to that, some dissection. Maybe in some cases we must be very, very cautious when we try to choose which patient is for ESAR versus ChEVAR. Yes, in that way.
Yeah.
How do you decide how many endoanchors you need to put on? So if you have up to 28, you put at least 4. If you have more than 28 in diameter, then you have to put 6 at least. But actually, the most we put in was, I think, 9. It wasn't needed 9. I think even 7 or 8 would suffice in the large anatomy. But it's actually, when you have good angulations and you can when you do it, it doesn't take much time. And if you're sure that you're doing a good anchorage, then it can be done without any problem. So actually 4 for a small anatomy, 4 to 5, no, and 6 to 8, I think, for the larger anatomy.
Have you ever lose any anchor?
No, never. If you follow the pass criteria, and if you are sure that you are opposed well to the aortic wall, and there is always this you have this backup plan. If you go for stage 1 and you deploy it in half, and you see that it's on the metal part of the stent graft, or it doesn't go through the fabric of the graft, you can easily pull it back and deploy it on the other place. So we never lost anything.
Have you ever put stent extension over the anchors?
Yeah, one time.
Because
one time, and it works, because it doesn't matter, because you have this the sharp one, the sharp edge is on the outside, on the aorta.
Edge it comes into the lumen of the stent graft.
Vjeko, theoretically or hypothetically, do you exist some I don't know, potential risk of rupture of aortic wall when you drill with the
it's altogether it's 3.5 plus 1, 4.5 millimeters in length, this EndoAnchor, no? And there always it stays in the aortic lumen, it stays at least almost 1 millimeter. So meaning that's a 3.5 millimeters through the graft, from the fabric of the graft and through the aortic wall. And I think it never happened. It wasn't described yet in the literature that somebody went through the wall and of the aorta. No, so I don't know. Everything can be done, as you know, in endovascular medicine, but I never heard about it. It's a very, very safe procedure, and as you can see, you saw it, and I know that you did the last week one, and or the 10 days when you had one, no? And it can be done, and this is simple and safe. So it's not very, very costly. So it's a good technology for some patients, no?
Thank you.
Thank you, Vjeko, for your answers. I think we came to the end, Dražen, right?
Right, we are on time.
Do you have any questions?
I think that we don't have any questions more. You can close or give some conclusions for our auditorium, please, Tomislav.
Thank you all for all attendees. Thank you for all questions. I think it was a good discussion at the end. We saw what is the hostile neck, what is the anatomy, and how to solve it. First, we see and saw the Professor Donas, who explained us how to perform ChEVAR, what are the indications, what are the limitations, what you have to be cautious with, and how to perform it, and what are the results, and what are the combination of the stent grafts and the renals and stent grafts in aorta. I think it was very helpful. We learned a lot. I think we can start to do it more in Croatia. And then another type of intervention, another type of the sealing of the proximal part of the AAA endograft for hostile neck. It's a very nice demonstration of a very nice and very interesting method with EndoAnchors. I know it performed well. I have opportunity to put it in with help of Vjeko in some cases. It went good. It went free of any complications. I think it's a good demonstration. Very nice, interesting method. I think it's very simple. You can use it in many cases. You don't have to be afraid of it. I don't think not any complication. I didn't see with EndoAnchors. So I can conclude it. It was a successful meeting. I hope we see you soon, right, Dražen? We have many different topics, interesting ones in near and future also. Can you tell maybe 2 or 3 sentences about that? Thank you all.
Thank you. Thank you all. Okay, I can announce in June our next webinar about clinical CT angiography interpretation before endovascular therapy. And that is all for this time.
Okay.
Thank you.
Thank you for all, and all the best.
Bye.
Bye.
Bye-bye.